हेलो,
पिछला केस आपका हो गया एक. Candidate would rather have Mustafa and Khalid than Saad Niaz. Let me be very honest with you. They can come and see me.
hello. Can you hear me?
Hello. Ji, Dr. Sabha, please can you tell us the case?
Okay. The next case is of a 38-year-old male with no known comorbids. He came to us with complaint of jaundice for about a month. His total bilirubin now is 4.2 and alkaline phosphatase is 246. His MRCP was done on 5th of April. That shows mild narrowing noted at the mid portion of the common bile duct, and a small single area is seen in the proximal part of common bile duct measuring about 3 millimeters, representing choledocholithiasis. Intrahepatic ducts are prominent. So the impression is of choledocholithiasis with possible stricture at the mid portion of common bile duct. We are proceeding with the ERCP.
Okay. So one of the things that we encounter here a lot is CLD. We all see a lot of chronic liver disease. And I think, platelet counts is something that's very important to look at before doing ERCP in Pakistan, definitely, for sure, along with INR. So as a practice, what I want to see is basically CBC and INR, really, when I'm doing ERCP, that's all. Okay. And,
what's your threshold for platelets for sphincterotomy? Okay.
CLD can be lower.
Yeah.
But otherwise 80 is good.
Yeah, no, for us it's 75 and for sphincterotomy.
What is the platelet count?
For INR. Yep.
So if somebody's got high INR and let's say 1.7 and who's obstructed, I think you can still do ERCP or 2 INR. There's no one stopping, but you should not do sphincterotomy. So in that case, you just go and put a stent in, come out, let the patient recover, and then go back again. Complication is there to do an
Lagi? Can you hear me?
Yeah, we can see you.
Okay.
You're looking very beautiful.
Thank you. Can you hear me though?
Yeah. Mustafa, what
We're
did
gonna-
he have for food last night?
I don't. Sure. I'll reserve.
Mustafa,
comment.
but I'll add one thing.
Yeah.
Today you're looking more yourself because you maybe caught a little bit of sleep, 2-3 hours.
Maybe.
Because he hadn't slept for like 30 hours yesterday, so he was totally.
Yeah. Go ahead. We'll try this.
Oh,
start
I'm so happy.
Go ahead. आप you're doing ERCP, right? Yes. कितनी है आपकी volume में? 40. और कहाँ? Where are you based? After.
Stores का जो वो होता है ना, जो surgical equipment. Okay.
Okay. What is this at the tip? Oh, that's just the
STORZ.
screw.
Yeah.
Okay.
To remove the.
Sure.
The surgical, so they are the kings, right? Laparoscopic. Yeah, if you look at the video images of this scope, the video images are amazing. I love
is
this
try to
silver
make
thing
this in your
in the
hands,
scope
like
because
you're comfortable doing
I think the scope should be silver. I don't know why they are black. I don't know, but it looks a little bit more modern.
It's different for
That
sure.
color.
Yeah.
Fancy, at least looks like you're in the new age, Naya Pakistan.
Yes. Go ahead and start.
Black is actually no, black is darkness, right? We need to come to brightness.
अब यहाँ पे DVI लिखा हुआ है।
हाँ ये नीचे, यस ऊपर, यस यही है नीचे।
ये
अच्छी हो वो हैव यू ओके ये तो साला डायरेक्ट जा रहा है भाई, डायरेक्ट रुक जा रहा है, मरवाएंगे यार।
या कह थोड़ा सा
You know, Mustafa,
यस
after you're done with this case, it would be nice to compare the flexibility of this scope, or the stiffness of this scope and the other scope that we were using.
श्योर
Yeah.
श्योर ठीक है, इज ही ओके? एक सेकंड रुक जाओ। रुक जाएगा, एक मिनट रुक जाए, वो डीसेट कर रहे हैं ना, तो आप आ जाए। So you have to keep so our patient desaturated, so as a physician, as a gastroenterologist, you have to be aware of the whole situation. So you have to look at the O2 sat monitor. It was down to 80%. Now it's come up to 94. So, and the pulse has recovered as well. So we just give it time and we wait for our anesthesia colleagues to say it's okay to proceed before we start.
End of the day, the responsibility is ours.
Exactly, yeah.
So you have to understand, if the patient desaturates or has an issue with anesthesia or with the procedure you are doing or the wrong selection of case, the responsibility will actually lies with us, because we are the ones who are, the patient is ours.
थोड़ा सा flex करके, नहीं आप वो तो ठीक है, your big wheel. Khalid does it slightly differently. I have it a slight come down towards you, or then go inside over the tongue, and then as you advance, you can extend, and it should go straight through. Good. The lights come kar sakte? हाँ जी. वो फुट पैडल का है, क्या जी?
कटिंग को पल्स कट पास को
ठीक है, नहीं वो मैं कहता फ्लोरो का दे दें।
आपको दूसरे में अपने पास
मुझे दे दें अगर आप माइंड ना करें तो। So there are different ways of using the fluoroscopy. I personally actually prefer to have the pedal myself. And at this stage, I usually get my scout film before I'm even in position, just to know where my scope is.
I do the same. I like to have my fluoro, but I mean, people also like to have their own wire.
Yeah.
Personally, my wire is usually with my tech, so
Okay.
and they are pretty good, so they know what we need.
Sure. Yeah.
We have our fluoro tech. Yeah, so he's it's a dedicated, he or she dedicated fluoro tech,
and it should just
and they're
go in.
really good. They know if I'm not looking at the fluoro, they stop the fluoro. If I'm looking at it, it's a good communication. So they're really used to
So you're in the right place. Just keep going. Just advance a bit. Right. Thoda sa you may have to big wheel away from your tiny bit.
Yeah.
Thoda sa big wheel away kare or advance kare. You have to keep advancing. Suction and advance.
Yeah. Exactly.
Advance, suction and advance your scope. Keep advancing. Thoda sa big wheel towards you and then advance. क्या हो रहा है? आपको resistance feel हो रही है? Drop your big wheel. The big wheel away from you. Is there a big wheel up? It should go. I don't understand. Big wheel towards you. You're right there. Thumb towards you. Small wheel to the right. Try करें. Up try करें. Advancing. Oh, you can see in the floor. I don't know if you see the floor. It's looping in the stomach. Let me try it for a second. So I think it's good to be cautious and not be over pushy. But I think you just have to, in this one, you just have to keep, it was just a slight angle adjustment. So I'm going to let you do that, okay? So advance, there you go. Suction, and then big wheel towards you, and then keep advancing. There you go. Okay, now slow down. There you go. Good, excellent. So we saw the minor papilla at the top, and now you're going to reduce yourself, right, into short position. Good. Now you want to optimize your papilla. I think it's not bad. Actually, what I would do is, there you go, slightly, not so much, but now you're in the zone, so you have to do small movements, right? The small wheel to the right a tiny bit, and big wheel slightly towards you.
They are the ones that are winking. Hello.
Yes.
Can
Right
you?
there.
Yeah. Okay. I just wanted to see the fluoro, just to see what the scope is like.
Sure. That's good. Actually, ready?
This position is good.
I think it looks good, right? I think you will find it once. At this stage, I usually get the sphincterotome down. इस पे बैग नहीं लगता?
यार हाथ
एक सेकंड.
please give me that bag.
उतनी देर we can study the papilla. You can see it's quite a prominent papilla, and the trajectory of the bile duct you can see if you go up, as Dr. Khalid was saying. You want to go up the middle of it. So if you go up there, that's where the bile duct's going to run. Oh, sorry. पीछे है बिल्कुल. So you can just go up. That's your trajectory, right? So now get back into position because you're getting above the papilla. लगा दें वापस वो. We're waiting for the bag. Bag आ गया.
What are we waiting for, Mustafa? Sorry?
The bag on the cap. वो,
It's all right. Let them. Oh,
well,
it's okay.
the cap wasn't punctured. So
Okay. No problem.
Yeah.
While you were looking there, the ampulla is constantly telling you, "I'm waiting."
Yeah, but this is a nice practice in restraint. Okay. Be comfortable with your setup before you start manipulating the ampulla.
I couldn't agree with you more.
Yeah, so I think that's the main. Elevators are
This plastic
Good.
bag system that we have, I think I had.
Oh, careful. Okay, so your elevator should have been locked all the way. Was your elevator
I went
locked?
to one of the units
pull
internationally and I
back.
saw this.
Relax
because
your elevator.
It stops this
Relax
splashing
it.
of fluids.
And now lock it.
So you just have a small.
All the way down. That's a lock. Now
a
push
small plastic
against it. Push against.
bag.
It should not come out.
Which
Are you feeling the
actually
resistance?
goes
Okay,
underneath the biopsy
when you're advancing
valve
anything,
and you push it.
it always
and,
has to
and
be
then
completely
any
locked.
secretion that
Otherwise,
comes
you can
actually
see
goes
that
into
trauma.
bag.
So let me just show you. So we were just discussing how not having the elevator locked can lead to this. Because the elevator wasn't locked and the cannula came right through.
Oh, I just actually before that I had told these people and I was just telling that elevator should be
Always locked.
Locked.
Because before anything comes out, you should feel it against the elevator, relax your elevator.
absolutely.
And then, by the way, on this scope, you can actually, camera is spread out, you can see the movement of the elevator away from the elevator with this detachable knob,
Oh really?
which is interesting as a sort of faculty observing your trainee, whether they're using the elevator or not.
Oh wow.
So anyway, the other thing I've just done is lock the small wheel slightly to stabilize it, and now I'm going to let you do the rest. Okay. So if you do, so before you go, start cannulating, if you pull back your cannula and see if the big wheel will take you closer to the papilla. So if you do big wheel towards you, that's good. And then just here you're just going to do small movements with both the wheels to see if you can, what's your best position. At this stage you can advance your cannula a bit and see, okay, again, small movements.
Can we see the fluoro image, please? I just want to see the position of the scope in the stomach.
How's that? Can you see it?
They have to change the fluoro image.
So that'll be, I think, on their end. Fluoro unko dikha de. Okay, now you're too far, okay? So you see, you can magnify kar sakte hain? So before you, what do you think where you are? So when that happens, अच्छा एक चीज़ मैं आपको बताऊं, in ERCP the movements have to slow down. This is not colonoscopy, this is not upper endoscopy. Once you're in the zone, you have to really slow yourself down and do micro movements. And one thing I'm going to show you, because we're in no rush here, but let me just show you one thing here. So every little move you do is going to make a difference. You do this with your wrist, it's going to make a difference. You do elevator up down, it's going to make a difference. Big wheel up down, you change your feet, that's going to make a difference. Your shoulders. So you have to use all these little movements to decide what is it that gets me into best position. And then scope in and out is going to make a difference, right? So you do all these little tiny movements. If you feel your assistant's too far and you're getting traction, you say, can you come closer to me? That you don't feel any tension. The focus has to be what gets me into the best position to cannulate. And then you do small movements here and there to get into best position. Now here the new variable is that this is a new scope. You and I both don't know what the best situation is for cannulation with this scope. So now look at my, so if I can't get into the right angle, I'm dropping my left hand to see if that gets me slightly better. And with time, these become second nature to you. But otherwise, not fast movements, small movements like this. Dusre, if there's too much motility, consider do I want to give atropine or not. Now we're getting closer gently, pushing in a tiny bit gets me under the papilla more. You can see now my scope is pointing more under the papilla. And here, when I'm training people...
Hello?
Yes.
Can we see the fluoro, please, and take the room? Yeah, keep it at that, please.
Okay. So then, the other thing I will do is I will basically, in this situation, even lock my big wheel. And when I feel that I'm quite optimized, that this is the best I can do right now, then I will consider cannulating, okay? So small movements to fine tune where you want to go and then see what you want to do. And this looks like a reasonable trajectory. I may still, in my mind I'm thinking I'm still pointing downwards and I want to go up towards the bile like this way. So I might have to cannulate and bow up a bit, but it all depends. So I'm going to hand it back to you and then you can see if you can, with small movements, get into position. Not large, big movements. And if you feel comfortable, then say I'm good, and then you can just go for it. Okay, so gentle. There you go. Okay, now what do you think? Are you in or not? Do you want your assistant to do anything? Because वो तो कर रहे हैं.
वो करें.
Are you engaged?
Yes, sir.
Okay, try wire. No? So we have to change our angle, right? Or do something different?
No. अभी वो करें.
जी मैंने कर दिया वो.
फुल वो करें.
फुल वो.
नहीं? So I actually end up in these situations. अब कैसे? So very nice. Good job, excellent. ठीक है? I've injected it. When you're ready. अच्छा, and stop. थोड़ा withdraw करें अपना कैनुला. wire ko dhyan rakhna. Okay, inject a bit more. Okay, it's not clear. Maybe there's a distal stone, but it's not clear to me. But at this point, we might as well get our sphincterotomy done
Yeah,
and then move on.
yeah, I totally agree. The duct
Okay.
is dilated for sure.
Yeah. So now you want to, before you, right, we're going to just slow down and make sure you're in good position.
Okay.
So what do you think? Is your wire in good position, do you think? That looks a bit better, right? Yeah, and then
How much I'll be in?
so that's a good question. So you can always pull back and reassess. So you can check, and there are different markers. So there's so the first blue is your start of your cutting wire, and as you advance a tiny bit more, you get, I don't know what, there must be a distance to that, and there's a lot of wire. One thing you can do, if you want the wire outside of the scope, you can move your big wheel away from you. As you move your big wheel away, you can get more wire out, and then you advance the tone, then you see more cutting wire. So that's one way. But the main thing is, this actually is giving you a bit better trajectory, but you have a lot of cutting wire. So you want to cut where your angle seems to be good. So I think overall this is good. The other thing is you don't have much contact because you're not bowed up at all. So you can do a gentle bit of bow, there you go. And here at this stage, my preference is to hold the scope with the right hand to give it stability. And I can also angle it left or right if I need to for sphincterotomy. Yeah, but that, when you do big wheel towards you, you're getting more wire in, so you have to be careful that you don't advance too much wire in the duct. I think that to me looks pretty good. So if you're ready, let your assistant know and you can start cutting.
Should I connect it?
I think it's good.
I think so is good. Yeah, I think that's good. And then just go slow. Too much tension will also cause a zipper cut, so you have to be careful. I think there's a bit too much tension right now. So just advance your tome a tiny bit. There. Okay, that's it. Ready? Go ahead and cut.
Go.
You ready?
Yeah, अपना right hand should be on the scope for control, and you can keep cutting. There you go. Keep cutting. You can cut right up that fold, right? So you can, if you drop your left hand towards the floor, it'll change your angle towards more to the left of the duct, which is where you want to go. So just drop your left hand. There you go. इसको नीचे को कर दो. ये और थोड़ा सा pushing करें, like that, and that. Then you now can cut towards the left. Okay, keep cutting.
थोड़ा सा आगे करें.
नहीं ठीक है, just keep cutting. See, your angle is good. Keep cutting. That's good. Okay, and then you can, those are the muscle fibers that Khalid was pointing out. You can see to the right, to the left, and you can see that there's still a mound to the horizontal fold. Yes. So maybe you can cut a tiny bit more. So just now you have to slow down. A couple more taps.
Okay. Here.
Okay, yeah, that's good. You have to make contact though. There you go. Maybe one more. And then I would maybe consider stopping here. That's plenty. So both power off. Yeah, I think that's good for now. Okay, now you have to exchange. So ठीक है? You're listening, right?
Are you sure it is?
So if you're not sure if it's enough or not,
enough,
you can always cut more, right? But if you overcut it and you have a perforation, then you have a problem. So is it like 100%? No. But is it 80? Maybe yes.
How much can we cut?
Maybe you can cut more up that fold if you wanted to. But in my practice at this point, I would do two things. I would inject a bit to see what's going on, and then I would decide whether to cut more or just start sweeping, because we haven't seen anything obvious yet. Right? So this may be enough for today. Inject, you did?
Inject.
Yeah, go ahead and inject. So pull through when you're injecting, pull through. Because you want to see how your sphincter looks. Pull through, pull through, pull through. So you may have a bit more sphincter, and you may have some stones, debris slides in there. Maybe consider cutting a tiny bit more, but I wouldn't get overly aggressive here. So advance your tone. Advance it into the... I don't think so. I don't want to cut more. I think we should exchange. Because if छोटे stone honge, then they'll come out anyway. Right? So now you're going to do the exchange, and you're going to speak very loudly to your assistant.
This CBD was, we couldn't see anything here. You agree there's nothing that we could see, or maybe there's a small thing that may be shown when actually the balloon sweep is done.
Exactly. There may be distal sludge or not. It's not clear to me. So exchanging. Okay, lock it in. How is the wire locking? Your elevator has to be all the way down.
It is locked.
Okay, now we're going to look endoscopically. You're going to look for the zigzags to see if they move.
Okay,
Okay?
I'm coming.
Good.
Yes, come please.
Or if you can't see, distend your duodenum. That's good. The image quality is very nice. Yeah, the image is very nice. On this one, the scope alignment worked out quite well. That, by the way, there is more mound you could have cut, just for your knowledge. The other thing you can see is a stone in the cystic duct, a large one.
This in the cystic duct or in the DV?
In the cystic duct, you can see.
Come back, please.
Keep exchanging. You can go faster.
Yes.
Keep going, keep going.
Yes.
You want your assistant to keep up with you. So you keep going because they will be watching your hands, especially the experienced ones. So keep going fast and look for the movement on the wire and keep going. Okay, now the wire is moving, so you may have to slow down, but you have to keep moving. So keep moving. There you go. And now what I would do is have your wire, lock it. The way you lock it is under your finger, over your finger, and under. Okay? So that, and your finger should be really against the scope. इसको दबा के रखने साथ ये उतरे ना हाँ ठीक है ना the idea is balloon sorry impatient
Balloon, basket,
Balloon.
extraction balloon.
ठीक है good so
This is 15 to 18 mm.
कितना है?
15 to 18 mm.
हाँ आपका duct का क्या size है
This is less 1 centimeter.
yeah about 11 10 11 like Highland में जाके it gets dilated so you know that you don't want it all the way up
Hold on.
full
यहाँ पे हम इसको थोड़ा सा अनलॉक करेंगे.
बिल्कुल आप अनलॉक करेंगे और एडवांस दूसरा कि if you lock it on the balloon you can actually tear the balloon so you have to be careful as you're coming out so go ahead and the first thing you're going to do is the mid duct looks okay right you can just start a sweep from here quite honestly just because all you want to do is clear the distal duct initially so you're going to say balloon up right so you go ahead and say balloon up
Get balloon up.
okay and now you're going to pull towards you right till it's snug.
Now it is not moving.
Okay, so now what you do is you lock it in your right hand, left hand. What Khalid said, you push your scope in a tiny bit,
And
push your scope in a tiny bit, big wheel up, and then small wheel to the right,
to the right.
and then you're gonna okay, not too much, and then you're gonna push your scope in as you put tension on the balloon. That's it. Keep going, keep going. So you get, now you're getting long position. So you got too far from it. You see that? So you have to have more tension on the balloon when you do that maneuver. So try again. It's just 8 seconds. Let me get you back into position. Balloon down. Yeah. Okay. Good. It's unstable again. So we're reducing the scope again because we went into long position. So you're going to stay under it like that, right? So we have to see where we are before you do this. Okay, so you get under it like this, small wheel to the right, big wheel up, right? So thumb down, big, you can even, again you can lock it if you want, especially the small wheel. Get under it like that, big wheel up, and then you have the balloon up, bring it up all the way, lock it in your fingers, and then you grab the scope, advance and turn clockwise. Okay, so there are multiple steps here. So you have to learn to control the balloon with your left hand, and you have to have tension on it as you do this maneuver. Okay, there should be tension on it. And is it all the way down? Is it as far down as it needs to come? یہ اس کو آپ نے پورا نیچے تک لے آئے ہیں. تھوڑا کم کر دیں. I think it's too big.
یہ چاہ رہے ہیں کہ تھوڑا سا کم کر دوں تاکہ
آسانی سے نکل آئے گا. ٹھیک ہے. Now you're going to try that maneuver. اس پہ ٹینشن ہی ہے نا. See, it won't come out unless اس پہ ٹینشن ہوگی. تو یہ بہت ضروری ہے. اس کو you have to learn to have tension on it. ٹھیک ہے. اور اب کریں. Almost. Keep doing it. Almost. Careful. Yeah. You're getting, I don't know if it's the balloon size, sphincterotomy, or the scope. But that's the idea, or your tension. Let me try once. You're almost there. Balloon down. Okay. So, okay. Balloon up. The balloon is up or no? Okay. So यहाँ पे आ गया, right? As close as possible, and then this. See, but this tension, I don't know what camera to need, but this tension is really important on the balloon. Okay, उसके बगैर balloon down. उसके बगैर what happens is that you don't have control of the balloon. So it has to be really tight up against the scope. So try that again.
Mustafa?
Yes.
Nothing came out, right?
Not yet. No.
Okay.
I think we'll do one more and then do an occlusion and be done. There, you can see the cystic is filled with stones, as is the gallbladder. Yeah. So go up more. Okay. Go up higher. Okay. Start now. Okay. That's good. So you can sweep from here. Big wheel up. Abhi I think we'll do one without, and then we'll do one last one with. Okay. Okay. And you can follow it on the fluoro. Okay. Okay. Now when it's snug, you have to keep it really tight against. Yeah. There you go. And then small to the right to get better alignment. And then you hold the scope with the right hand. And then advance firmly. There you go. Keep going. There. You just came through, right? Did you feel it? Yeah. And then balloon down. Relax your wheels and pull back a tiny bit. Pull back your scope a tiny bit, and we'll go right back up. Pull back your scope.
scope to that.
There you go. And now you can advance it again. Okay? This time we're going to do an occlusion. वो जो fibers थे ना हमें फिक्र के maybe we can cut more. Now you can see the duct inside. Well, we could have cut more and we could have ended up with a perforation, right? So you don't have to cut 100%.
Okay.
You can see the.
But we can cut more.
I wouldn't cut more. Okay. Why would you want to cut more? Okay. What is the goal here? Adequacy, right? The goal is, can I achieve what I want to achieve with cutting? And if not, at this point I would stop regardless. Even if there was a 2 centimeter stone, I would balloon dilate from here. I wouldn't cut more.
Well, if I want to cut it more, I will cut the inner side or only the outside.
If you really wanted to cut more, you could try and cut more on the inside, but you may end up with a perforation. And that's why I would say that this is enough. I've achieved a big sphincterotomy, and it's safe to do balloon dilation without causing pancreatitis, if I needed to. Okay, go ahead and do a quick sweep, occlusion, and then we should be done. Right, so go up all the way. Good. Watch the wire. Okay, balloon up.
Fine?
Yes.
Is Dr. Sajda around?
Okay, balloon up.
Not seeing her right now. No. Okay, inject. Yes. Okay, slow down. Okay, you want to let it fill, right? Inject. Okay, now come through. Stop, come through. That's a bit of air above the balloon, so we don't worry about that too much. Balloon thoda shat kam karna padega. Thank you. Or that's all air bubbles. So those can give a false positive, and there's nothing there. So I think we just pull out and suction and be done. We're done. Very nice. बहुत से. First time cannulation and sphincterotomy, which can. Good.
मैडम बंद कर दे थोड़ा 2-3 मिनट पहले मिनट ना
और stomach deflate कर दो. Section कर दो. अच्छा आप निकाल के ना, what I would like you to do is leave your gloves on and hold the scope for a second. वो तो साफ है ना, लिपस से साफ है.
ये तो
हाँ.
Should I stop the recording?
You can stop it, yeah. Because I want to, Dr. Sadhna has wanted us to compare the two scopes for their flexion.
Sir, are you satisfied with our scope?
Sorry?
Are you satisfied with our scope?
This was good. This was very good. The image quality was excellent, actually. Case तो उन्होंने किया है, so he knows. जरा करें अपना wheels relax करें. Are we still recording or are we still transmitting?
It's recording.
Okay, let's just show them. So we have the two scopes side by side, so thumb down. All the way down? All the way. Full flexion. All the way in.
There are two things I wanted to check.
Yes.
एक तो ये देख लें कि this is
And the other way? And that's good. Or
and the overall stiffness as in the scope when you feel holding it from the, you feel that this is as stiff as that one, although that one is an old scope.
I was going to say this one's seen more wear and tear. I took my gloves off, but let me just see.
Gloves दो.
No, हाथ धो लो. कोई नहीं, I'll wash my hands. कोई नहीं. ये नया है, but it's more, I think it's got more sort of malleability than the Olympus.
It feels more flexible, doesn't it?
Yes, it does.
Yeah.
Yeah.
And I think that's one of the reasons why maybe, when you're advancing into the pylorus,
Yeah.
it kind of
forms
makes a
that
bigger
loop.
loop in the stomach because
Yeah.
it's more floppy
Yeah.
or less stiff.
Less stiff. Yeah.
But the tip is fine.
The tip is actually really good, and I'll say the image quality is very
Image
good.
quality is excellent.
It's excellent. But yeah, they can look at this sideways movement.
Yeah, it's pretty good.
That's very good. Yeah.
I think it
Wow,
just-
look at that. I don't know what you can do with that in an ERCP, but
but I have to say the image quality is impressive.
exactly. Yeah. I will say I have had the, in quotes, pleasure of using the Pentax ERCP scope, and this functioned better because that's an even more flexible scope.
Really?
This, yeah, and this functioned better than the Pentax, but I have nothing against Pentax. That's just,
Neither do I.
yeah.
Okay.
So. Thank you, Doctor. Okay, thank you.